normally we establish a prognosis at the beginning of a treatment before we start doing things. And for sure, depending on the way we treat the patient, depending on the motivation that we cause on those patients, things can definitely change, right? So what do you think is, from my point of view, what do you think which is the most important from those three factors, the tooth, the patients, or the dentist?
I would say the patient is the most important factor. The tooth, I would say, is the least important factor. But I disagree. We do prognosis in the beginning of treatment. However, we have to redo and repeat prognosis on the way. Because if I see the patient for the first time, so I do my examination, I get my data, I get my information. However, I don't know really the patient. And I said,
we don't know it.
Yeah, we don't know it. And before non-surgical therapy, you never should do a final prognosis, because with non-surgical therapy, the result of non-surgical therapy is an element in prognosis. If it works well, this is a good sign. This improves prognosis. If it does not, so it becomes more difficult. And one point, don't extract teeth too early. So if there is a patient, continuous dentition, possibly some, so to say, hopeless teeth, for the non-surgical therapy, I would leave them in, try to treat them. Non-surgical therapy is cheap, it's easy, not so easy, but it's easier than doing surgery. And sometimes, or in many cases, it works out well. Hopeless teeth may be transformed to questionable or even poor. And so this is a big improvement. And as I have shown yesterday, if you remove teeth, you may have a hopeless tooth, and it may have teeth with poor prognosis that are adjacent. But if you have removed the tooth, the adjacent teeth become potential abutment teeth. A tooth with a poor prognosis may be retained as itself, but it may be difficult to use it as an abutment tooth. So I try to avoid premature extractions. I try to do non-surgical therapy, and then I re-evaluate. And so the message is, try to improve prognosis. But this is on a tooth level.
So from your point of view, probably the proper approach should be visiting our patients, establishing a diagnosis, do a phase 1 therapy, wait probably for the reevaluation, a couple of maintenance visits, supportive therapy,
yes,
and then redecide what we should do with our patients?
Exactly, and in most cases, time is on our side. I have the experience in some patients, you do re-evaluation after non-surgical therapy, so it's better, but it's not good. So you could say, okay, we do surgery at once, but if you don't need prosthodontics, so if the patient is patient and he can chew, so you can wait. So do another supportive treatment, another re-evaluate again, and in many cases, conditions improve, and if you don't have the need to rehabilitate, then you have the time. Another reason not to prematurely extract teeth.
So maybe we should start changing the paradigm and start thinking that 6 weeks for a reevaluation, it's too short, or maybe we should establish a proper treatment plan after maybe 6 or 8 months of supportive therapy?
From my point of view, 6 weeks, this is for surgery lovers. Because after 6 weeks, you have many pockets left. So in my clinic, we take 3 months. And even after 3 months, so if it's on the way up, if it's improving, we discuss with the patient, so let's wait maybe another 3 months, another 6 months. Let's wait and see, because surgery, we can do it later.
There's always time for the surgery.
There's always time, and patients like to avoid surgery, I can tell you.
That's the thing. I teach at the university, and normally we decide a surgical treatment plan after 4 or 6 weeks of phase 1 therapy. And sometimes you decide to do 4 surgeries in the 4 quadrants, and you start with the first quadrant or the first surgery, and then we normally wait around 3 to 4 weeks for the second surgery, 3 to 4 weeks for the third one, and sometimes when it's time for the third surgery, you find out that area it's out of pocket.
Yeah.
I mean, it's completely clean. So maybe we should, for establishing prognosis, it would be rational to wait maybe a little longer to know better the patient, and actually probably 1 month or a month and a half is not time enough to teach our patients for proper cleaning, right?
You learn to know the patients better if you take time, and the patients better understand the concept behind the treatment. So if there is no need for a hurry, I would advocate to slowly go ahead.
And how do you think that probably education on our patients should be an important factor for changing the prognosis in the future?
It's a big discussion in Germany, actually. The discussion, what about the professional tooth cleaning? From my point of view, it's more important to educate our patients, to talk to them, to explain the disease, how we treat it, how it works, how we can stop the disease, than to clean the teeth. So the improvement of, we do both. We educate and we clean, but some people think, okay, it's professional tooth cleaning is everything, so if the teeth are cleaned, I'm off, it's done. It's not, because with professional tooth cleaning, you cannot replace the individual oral hygiene at home, and it may be boring, but in periotherapy, we are still dealing with the biofilm. Sorry, we are not the inflammation doctors. In a way, we are, but we influence inflammation by influencing the biofilm, by removing the biofilm. That's still the concept. That's still what we do.
So maybe the absence of information or the wrong information, it should be included as a risk factor for periodontal disease in our patients.
Absolutely. We have to talk to our patients, and communication is a major issue. Absolutely.
I think that we're actually in the proper place, because SEPA meeting this year, it's over 6,000 people, 6,000 attendees. And I think it's probably not politically correct to say it, but sometimes I say that a bad dentist is a major risk factor for periodontal disease, because I don't know how it's in Germany, but in Spain we deal with patients that are probably in their 60s and they have advanced periodontal disease, and when you give them the diagnosis, they sometimes surprise and say, it's like, how could it be? I've been visiting my dentist for the last 40 years and no one ever told me this. So probably information not only for the patients but also for the dentist from a periodontal point of view should be more important.
Yeah, the point is there's a nice study by a Swiss group, and they have sent different cases to the colleagues in Switzerland, and they asked for treatment planning according to clinical data and radiographs, and they asked the dentists what is their major interest. Is it prosthodontics? Is it surgery? Is it perio? And in the end, it came out If you attend a dentist that is only interested in periodontology, so you have a higher chance to retain your teeth. So this is, philosophy,
Yes.
the treatment philosophy, how you are educated. I think this is, it may not be politically correct, but it's a fact. There's evidence for it. And there's a lot behind it. It may be that these conservative approaches, just wait and see, clean, wait and see, it may not be economically attractive to do such treatment. I'm not sure, because it is cheap for the patient, but it's cheap for the dentist as well, because you don't need a lot of equipment for it. So if you organize it well, I'm convinced it's a good economical concept as well, especially because you bind your patients to your practice if you have a prophylactic approach. The supportive treatment system, you see the patient every 6 months, every 3 months. So there's a narrow relation, and some things happen then. There may be a filling, there may be sometimes teeth have to be removed. We try to postpone it, but anyway, there is enough cases that you have to do implants someday, but the later you do it, the longer the implants will be in place.
So apart from all this theoretical or maybe inspirational, bucolic part of diagnosis and prognosis, moving a little bit forward, what science is offering us today, how do you think the new technologies or the new lab discovering that we have will change our possibilities of offering a more accurate prognosis to our patients?
I'm sorry, but I don't see so much new things. It's still the probe. Some colleagues are disappointed. They would like to have a laboratory test. If you go into the literature, there was in the 80s, 90s, Stephen Offenbacher, prostaglandin E2. But you see, with the probe, you may get information from 168 sites in a mouth. Different information. Try this with a laboratory test. You don't have the time for it, you don't have the money. This complicated information we may retrieve with a probe. If you do, let's say, this matrix metalloproteinase 8 test, it's very popular with the collagenase. This is a whole mouth test. So you may get the information, there's a higher level of inflammation in the mouth, but what's the consequence? What tooth should you treat? With the probing depth, you know, okay, there's a deep pocket, I have to re-instrument, I have to possibly place a local antibiotic whatsoever. So I don't see actually anything concrete that we could use. What I expect is with the new microbiological tests, well, it's not tests, it's not the species anymore, the single species, but it may be the whole oral microbiome, how it is structured, its diversity, its richness, its new technologies. But I don't see that we have a commercially available application of it.
And if we move instead from a local point of view to more of a systemic point of view, is there anything that you would like to have if we had a genie today that we could ask something special that could help us from a systemic point of view of our patients to help us predict the life or the trend that those teeth will have?
Yeah, if we know that there is a genetically predisposition behind periodontitis. It may be 50% of the whole disease that is maybe explained genetically. The problem is it's not one gene, it's many genes. If there would be a test that checks the different genes and that may give me something like 30% genetically explained, 50% or so. But anyway, I would like this. But anyway, what's the consequence? So if I know there is predisposition, so possibly I say, okay, you have to come more frequently for SPT. Nutrition may be a topic, but if you look to the studies, there's a nice study from Germany, from Freiburg. It's a randomized controlled clinical trial where the test group had to change its nutrition substantially. But if you read this, and if you imagine that you had to change your eating in this way, then I say it's easier to teach people to brush their teeth more effectively. Because, you see, nutrition may make a difference, but it's not easy to change your way how you eat. So
okay.
It may be not so much new. So we have no 100% success. But with most patients, I would say in 90 to 95% of our patients, we are successful with our current concepts. And that's not so bad.
I like to be very positive in all the things I do. I believe that oral hygiene and education is probably the best way to change the prognosis of the life of the teeth of our patients. But I also believe that technology and science, like medicine, has improved in the last 10 years more than the previous 50 or 60 years. So I believe that if we continue with these trends, probably in 10 more years, we will find some nice things. I hope I can live to see all those things, right? But for sure, oral hygiene is definitely the most important thing for predicting the future, right?
The point is, I'm in periodontology now for 25 years, and I've seen a lot new technologies. And I have seen a lot of new technologies that did not work, that we don't use anymore.
They're not as good as a toothbrush, right?
Yeah, this is still valid. Oral hygiene, you could say with the Stone Age diet, you may have the biofilm, but you may not have inflammation. There is data on it, but we are not in the late Stone Age. We have the grain nutrition, and we have this type of plaque, and we have the sugars in our diet. So we may change. Very difficult. I could not change. I will not. Without ice cream, this is not. Life would not be the same for me. So I have to brush.
Peter, so for the young generations, if you had to give a take-home message or a conclusion from your lecture yesterday, what do you think we should take home and start thinking of from Monday morning?
I think the nice thing with perio is that you get to know your patients, you follow your patients over a long time. When I started to do perio, I liked surgery. The fancy surgical things. In the meantime, I like to see patients returning to my office that I have in treatment for 10 years, and I see, okay, severe case in the beginning, no tooth extracted so far. This is what I like in the meantime, and this is something. So perio, what's my message? So perio is a nice subject, and it gives you a lot of satisfaction in saving teeth, in saving chewing function, maybe with simple means.
Okay. So is there any question in the audience or someone interested in knowing something else? No? So Peter, thank you very much. It was a great pleasure doing this interview to you. And I hope to see you again in CEPA for many, many opportunities.
Muchas gracias.
A ti.